All right. We're going to talk a little bit about soft tissue trauma. Soft tissue, of course, refers to the skin, muscle, ligaments, tendons, all those sort of things. So soft tissues are skin, they're fatty tissues, they're muscles, they're blood vessels, connective tissues. Connective tissues would be your ligaments and tendons, membranes that surround your muscles, glands, nerves, all the things that are found in your layers of skin. So here's just an example of, those soft tissues. You've got skin, you've got fat, you've got muscle, you've got blood vessels, you've got membranes between the ribs there, bone, which is considered hard tissue, and then you've got your nerves and organs below the soft tissue. So the major function of soft tissue, or the major function of skin, is that it does provide protection from the environment. It helps regulate your water balance by sweating or not sweating. It helps regulate your temperature by sweating or not sweating. It helps excrete. You excrete medicines through your skin. You excrete toxins through your skin. And the skin will also act as a shock absorber when you're struck by a traumatic force. If you take your hand and you put it on your scalp and you slide your scalp back and forth over your bone, this sliding motion of the scalp, the sliding motion of the skin is a great shock absorber. It only takes about 70 pounds per square inch to punch a hole in your skull, but it takes 300 pounds per square inch to lacerate your scalp. And that's just because of how much the skin will move and absorb trauma before it actually tears. When we look at the layers of your skin, you've got the epidermis, which is the outer layer. It is constantly being regenerated, and as dead skin cells slough off and new ones take their place. You've got the dermis, which is below the epidermis. That's where the skin cells are. There's like 7 layers of skin cells. And then you've got your subcutaneous layers. And within the subcutaneous layers lie your nerves, your sweat glands, your hair follicles, your fatty tissue, all that stuff that we mentioned already lies in that subcutaneous layer. Now, wounds to soft tissue can be classified as either closed or open. A closed wound would be that the skin is intact. An open wound, the skin would be broken. So here's a diagram of the skin, and you can see you've got the epidermis, the dermis, and the subcutaneous layer where all those things do lie. The nerve, the veins, the arteries. Within the dermis are the sebaceous glands. The erector pili muscles are what give you goose pimples, certainly allow the opening and closing of pores in your skin. And close to the skin's outer layer, of course, are sensory receptors that sense pressure, pleasure, pain, hot, cold, those sort of things, and send that information back to the brain. Closed wounds are internal injuries with no pathway from the outside to the injured site. Now, although the skin may be unbroken, there may be extensively crushed tissue underneath. And closed wounds can be minor, like a bruise, to life-threatening, like severe abdominal trauma. Or in the case of soft tissue, you could have a crush injury to the leg causing a rupture of the femoral artery. Closed wounds, we see contusions, which is another word for bruise. We see hematomas, and that's similar to a contusion, but there's usually the result is the result of more tissue damage and involves larger blood vessels. A bruise is bleeding under the skin. A hematoma is bleeding under the skin, but it's a big pocket of blood, often referred to as a goose egg. Closed crushed injuries are the result of excessive crushing forces, which can rupture internal organs and those internal organs, particularly the solid organs, are going to bleed excessively, causing shock. Blast injuries. Remember, with blast injuries, there are 4 different types of injuries that occur during a blast. You've got the primary injury, which is the result of the pressure wave. That will cause blunt trauma to both your solid and hollow organs, affecting mostly your air-filled organs like your abdomen, your eardrums, even your head, your lungs. And then you have your secondary injury, which is from flying debris. And then you have your tertiary injury, which is being thrown to the ground by the blast wind. And then you have the quaternary injuries, which are the result of breathing in noxious fumes, exacerbation of your existing medical problems. Like if you have asthma, breathing in all the dust and stuff may cause an asthma attack. So there's your contusion, there's a rupture of a hollow organ, there's an internal laceration or puncture, crush injury, and injury to solid organs from a blast. So these are all closed wounds, and the severity is really determined on how large the closed wound is and what organs lie beneath, because, you know, trauma is the application of force to the body, causing disruption of the tissue. And of course, the larger the closed wound and what organ lies beneath there determines the severity of a closed wound. Bruising may be an indication of internal injury or internal bleeding, particularly if you see bruising of the abdomen. Consider the mechanism of injury. Was it an injury that was significant enough to cause internal hemorrhage? You know, if I'm wearing my lap belt too high and I have a rapid deceleration and I compress my abdomen tightly against my lap belt, it can cause bruising all across my abdomen. But more importantly, the organs that lie underneath there were squished as well, and I could have a ruptured spleen or even a lacerated liver. You want to take appropriate standard precautions with closed wounds because they can become open wounds. Your care for all trauma patients is ABCs. If their airway is not open, open it. If they're not breathing adequately, breathe for them, administer oxygen. And if they're bleeding, control hemorrhage. Always manage as if there is internal bleeding and shock if the injuries suggests the possibility of internal injuries. Splint your extremities that are painful, swollen, or deformed, and there's a variety of different types of splints out there, and in your labs and practice you'll use a bunch of them. Just remember the basic principle of splinting. Immobilize the joint above and below the suspected fracture. What you use varies widely depending on what you have available to you. Stay alert for vomiting, which is a sign of shock as well. Continuously monitor for changes in vital signs. Seriously injured patients every 5 minutes, not seriously injured every 15. You can apply cold pack to an isolated ankle swelling or isolated wrist fracture, or elbow dislocation, something like that. But remember, we don't want to make the whole body cold, causing hypothermia, because that could make any internal bleeding as a result of the soft tissue injury worse. Types of open wounds include abrasions, lacerations, penetrations, avulsions, and amputations. Open crush injury, bite wounds, blast injuries, and high-pressure injection injuries from things like hydraulic lines. When dealing with an open wound, you want to pay strict attention to standard precautions, wearing gloves as a minimum, and if there's a lot of blood, certainly eye protection, face protection, and a gown would be appropriate. With an open wound, you want to expose it. You want to clean the surface of the wound with water, control any bleeding if it's serious. add oxygen with the controlling of hemorrhage and treat for shock by keeping them flat and keeping them warm. You also want to prevent further contamination into the wound. Apply sterile, clean dressings to the open wound, and then a bandage to hold the dressing in place. Keep the patient still and reassure them. When we have abrasions and lacerations, we want to reduce contamination, and so we can, if the bleeding isn't severe, certainly wash that out with some water or saline, and then hold direct pressure to control any bleeding. Do your circulation motor sensory checks before and after any sort of procedure to an extremity. For penetrating trauma, use caution as the objects may be embedded deeper than they appear. Look for an exit wound. And remember that bullets, when they go into the body, if they mushroom in it or if they break into smaller pieces, then we have different cavities in different directions. And if a bullet hits a bone, it certainly can fracture the bone as well. Stab wounds are serious, especially if they're in any area of the body where a vital organ is present. So any stab wounds of the abdomen near the spleen or the liver, any stab wounds, of course, of the heart, or the anywhere around the sternum where you have the mediastinum, which holds the heart, and the 8 great vessels. When treating penetrating trauma, again, reassure the patient. Look for exit wounds if we're dealing with ballistics, if a person's been shot or they've got an impaled object. Assess the need for CPR. Whether or not you immobilize the patient on a board or vacuum mattress or scoop stretcher or something is going to be up to your local protocol. Do know that patients with penetrating trauma to the neck, if they don't have obvious signs and symptoms of spinal cord injury, then there's no reason to immobilize them and transport them to a facility capable of caring for their wounds. Now here with the penetrating trauma, just remember that once the bullet goes in, the path isn't always predictable. Look for an entrance wound and an exit wound. The entrance wound is going to typically be much smaller than the exit wound because of cavitation. Just remember that as the bullet travels through the body and loses speed, a cavity is formed around that bullet, which stretches and tears all kinds of tissue. A handgun, the cavity is 5 times bigger than the projectile, but with a high-powered rifle, the cavity is often 15 times bigger than the projectile. Don't remove impaled object because they may be tamponading the bleeding, and pulling them out may just cause severe bleeding. Expose the wound area where the impaled object is. Control any bleeding around the impaled object with firm fingertip pressure. Apply several layers of bulky dressings to help stabilize the impaled object in place, and then secure those dressings with a bandage. That should all help that impaled object not move around. Treat your patient for shock. Keep them at rest. And when we talk about treating for shock, that's keep them flat, keep them warm, administer 100% oxygen, and provide safe, effective, rapid transport. And reassure the patient throughout all aspects of the care. If a person's got an impaled object in the cheek, in their face, take care that if the object obstructs the airway, then it's got to come out. And you certainly can remove an impaled object from the mouth or the cheek so that it doesn't cause airway obstruction or doesn't cause nausea and vomiting. External wound care will not stop the flow of blood into the mouth, so you might have to put a 4x4 or some sort of dressing in the mouth and something on the outside as well. Examine the wound inside and out. Remove it if it can easily be done. Sometimes we talk about keeping the patient flat, and certainly if I'm bleeding into my mouth from soft tissue trauma, lying me flat is going to affect my ability to manage my airway. So you might have to put me in a recovery position, or there's nothing wrong with, especially if there's no evidence of spinal cord injury, there's no there's no reason you can't sit them upright and have them lean forward so that they can drain out of their mouth. Provide them oxygen and treat for shock. If a person has a punctured wound or something of the eye or the globe, any impaled object into the eye, you want to stabilize the object. You can apply rigid protection. Here they're referring to the classic, oh, you've got a pencil stuck in your eye. Well, I'm going to take a big styrofoam cup and I'm going to put it over the pencil and cover it to stabilize it, and then wrap bandages around the styrofoam cup to protect that. Remember that if you do secure one eye, you have to cover the other one as well. If you leave one eye open so that they can see, the eyes move together. So if you allow one eye to be able to see, the uninjured eye, if you don't cover it, every time they move that uninjured eye, the injured eye is going to move as well. So, cover both eyes. Understand that you've just made them blind and you need to, communicate with them. Consider the need for oxygen if there's any evidence of shock, and reassure the patient and provide emotional support. Again, reassurance isn't everything's going to be okay. Reassurance is we've got the bleeding stopped, your vital signs are stable, we're getting you to a place that can care for your injuries. Because they may ask you, particularly if they have something impaled in their eye, whether or not they're going to lose their eye. You don't know. Certainly, more than likely they're going to lose their eye. But I've had people who've had a dart stuck in their eye and they still have their eye and they still have vision in that eye and that sort of thing. So you just can't always be sure. So reassurance is more of, we've got things under control, your bleeding is stopped, your vital signs are stable, we're taking you to a place where they can care for your injury. If you've got an avulsion, which is a flap of skin, you want to clean the wound surface, fold the skin back into its normal position, control bleeding with direct fingertip pressure, and then a bulky dressing. If the avulsed part is completely torn off, you want to, if you can find it, save it in a sterile dressing and keep it moist with sterile saline and cool with a cold pack if that's all you have. And that will salvage that tissue that may be able to be sewn back on. With amputations, take steps to control the hemorrhage immediately. Partial amputations are going to bleed more than complete amputations, but if there is massive bleeding from an amputation and you can get a tourniquet on it, put a tourniquet on it and control hemorrhage right away. Apply direct pressure with fingertip control. Pack any gaping open wounds with dressing or a hemostatic dressing to try to control the hemorrhage. If the amputated part can be recovered, you want to wrap that in a sterile dressing and secure it. Put the amputated part in a bag and then put that bag in a cool, cold place. Now, some people will, if the amputated part is small enough, we're talking a finger or fingers, those sort of things, put the fingers, wrap them in a dressing, put the dressing in a Ziploc bag, and then put the Ziploc bag in a bag containing ice or ice and water. Don't immerse the amputated part directly in water or saline. It'll become overhydrated. It'll fill up with water and can damage the tissue. With genital injuries, there can be bleeding, particularly severe bleeding, because both the penis and the vagina are quite vascular, and the soft tissue in those areas, when damaged, can cause bleeding. So you control bleeding, but we're not going to, pack a vagina that's bleeding. You want to use, a sanitary napkin, ABD pad, something over the outside soft tissue with, a little bit of direct pressure, but we're not going to, pack anything in the vagina. You want to preserve any avulsed parts. If they have a genital injury, make sure that you look around to see that they don't have an injury somewhere else. Display a calm, professional manner, and then consider the possibility of the injury being the direct result of a crime. Burns may involve more than just skin level structures, and oftentimes we can't see the internal damage that can occur as a result of a burn, particularly burns caused by electricity. If respiratory structures are affected, swelling may occur. They may develop acute pulmonary edema. They may develop upper airway obstruction, which you would hear inspiratory stridor. But don't let the burn distract you from other types of injuries. Burns are soft tissue. Certainly they do things like skin grafts, donor tissue, those sort of things to try to uh, uh, restore the skin integrity of a patient who has been burned. But don't let that burn distract you. It is soft tissue trauma. Don't let it take you away from managing the airway, making sure they're breathing adequately, and making sure that they're not hemorrhaging. Burns are classified as to the type and the depth and the severity. When we are classifying burns by the agent and the source, the agent might be a chemical. Was it a chlorine burn? Chlorine as a gas, when it gets trapped between your clothing and your skin, forms the chlorine combines with the moisture on your skin and forms hydrochloric acid. Same thing if you were to, drink liquid chlorine or inhale chlorine fumes. Those fumes combine with the moisture in your respiratory tract to form hydrochloric acid, causing burns. Electricity, burns again caused by electricity. We just really don't know how severe the injury is, because as the electricity travels through the body, depending on the path it takes, it can cause severe damage to internal structures that we can't see. So you want to report what the burn was caused from, and gather as much information as you can. Now, burns can be superficial, they can be partial thickness, or they can be full thickness. Some would call them superficial first-degree burns, partial thickness or second-degree burns, and full thickness or third-degree burns. First-degree burns or superficial burns, the skin is reddened. Partial thickness burns, the skin has blisters. Full thickness burns, the skin is charred, leathery, black, or white. And that's what this says here, is that the superficial burns are first-degree burns. They involve only the epidermis. They'll be reddened with minor swelling, very painful. Partial thickness burns are second-degree burns. The epidermis is burned through. The dermis is damaged. The pain is deep and intense. There's noticeable reddening, blisters, and sloughing or mottling of skin. Full thickness or third-degree burns, all layers of the skin are burned. They're burned clear to the subcutaneous layer. The areas are blackened. They could be white, dry, leathery patches as well. When considering how severe a burn is, we talk about small burns and large burns. Small burns are less than 10% of the body surface area. Large burns are greater than 10% of the body surface area. So we look at what caused the burn. We look at what part of the body is burned. We look at the depth of the burn. We look at the extent or the percentage of the body surface area. The age of the patient, because the very young and the very old don't tolerate burns well at all. And then whether they have any comorbid factors, or they have any other illnesses or injuries. We can use a rule of nines to help us estimate the extent of the burn area. The adult body is divided into 11 main areas, and each area represents 9% of the body surface area. So we see here the head is 9%, the front of the arm is 4.5%, the back of the arm is 4.5%, each arm then equals 9. The front of the abdomen is 9. The front of the chest is 9, the back is 9, the lower back is 9, and you can see the rule of nines. Now, when we get into children and we get into infants, the percentages are quite different. Children have much larger heads than adults, so where ours would be 9%, theirs is 18%. So, you can use the rule of nines, but perhaps one of the most easiest ways of determining the percentage of body surface area burned is a rule of palms. The patient's palm size, not their hand size, but their palm size, is equal to 1% of their body surface area. So if the burn is greater than 10 of their palms, regardless of whether it's first, second, or third degree, that is considered a big burn. The reason we classify burns is that'll help us determine the order and the type of care that we provide and the order of transport or whether or not this merits taking them to a burn center. Now, we used to have specialized burn centers, and I guess we still do in areas of the state, but most of the burn centers are just now part of the trauma centers. So we take a patient initially to a trauma center because burns are trauma, and they would be treated there. And then if they needed care or extensive care for their burns, they might be moved from there to a major burn center. A moderate burn in a young adult can be a fatal burn in a geriatric patient. A geriatric is patients over the age of 65. So, we have to be just aware that elder patients just don't tolerate burns as well. And what may be a moderate burn in a young adult could be fatal in a elder patient. Again, children and infants have a much greater relationship of body surface area to the total size of their body. So in addition to the rule of nines being different, they also have greater fluid loss and they have greater heat loss because of their larger body surface area compared to their mass or what they weigh. As a result, pediatric patients who are burned can become hypothermic quite easily. Remember, burn is trauma and hypothermia is bad for trauma. So we need to keep these patients warm. Otherwise, they could go into shock. Now, when we look at treating specific types of burns, patients who have thermal burns from heat, we want to stop the burning process. Now, what that means is if they're on fire, put them out. If they've got hot coal or hot tar stuck to their skin, you need to cool that hot tar. What it doesn't mean is all burns should be cooled in water. Your body will cool the burn itself in about 3 minutes. However, the pain, especially if it's first or second degree burns, can be extremely painful, and running cool water over it does help alleviate some of that pain. Now, if the body surface area burned is less than 10%, it's okay to cool the area with water. But if it's greater than 10%, we increase the risk of causing hypothermia, which would be detrimental for a burn, particularly a burn that large. So once we put the fire out, we want to ensure an open airway and assess their breathing. Look for signs of airway injury. Are their nasal passages full of soot? Is their mouth full of soot? Is their nasal hair singed? Do you smell burnt hair? Do you hear any sort of inspiratory stridor, which would indicate a inflammation or swelling of the upper airway? You want to complete your primary assessment looking for life threats, and if the patient is shocky, treat for shock again by preventing heat loss, keeping them flat, keeping them warm. You want to evaluate the depth of the burn, the degree and the extent and severity of the burn as well. It says don't clear debris. You don't want to be debriding that burn. That's something they'll do in the hospital. Nothing says if it's less than 10%, you can't pour cool water over it and wash out some of that debris, but to actually pick stuff out or rupture blisters or those sort of things or pull off dead skin, that's not something that we do in the field. You do want to remove clothing and jewelry because the body will swell as a result of the burn, and we may not initially see the swelling, but they'll start to swell. And jewelry that is loose may be not able to be removed by the time you get them to the hospital. Wrap the burn with a dry, sterile dressing. And we already talked about removing jewelry. With chemical burns, we want to, if it's okay, we want to flush the chemical with copious amounts of water. Water, 20 minutes of soap and water. If it's a dry chemical, you want to use a lint roller rather than brush it out into the air for everybody to breathe. Just use a little lint roller to try to get the dry chemical off. For chemical burns, whether it's wet or dry, remove and isolate the clothing. Remove the clothing, put it in a plastic bag, tie it up, because many of these chemicals give off noxious fumes. So we don't just want to pile them up in a corner. We want to isolate that clothing. And then we want to flush with large amounts of water, soap, and then water and soap and water. About 20 minutes worth. This can be done in a warm shower. It's often done in business and industry or in the home prior to EMS getting there. If they have a chemical burn, again, remove and isolate their clothing, sterile dressings for the burns. If there are any signs of shock, treat for shock and transport. Radiologic burns can occur from exposure to high levels of radiation. If they're close enough to the ground zero, the burns can be immediate, or if they're far enough away, the burns can be quite delayed. And there's a great number of sources of radiation that are out there, and without specific monitoring equipment, we're not going to be able to detect it. If we're aware that the patient has been exposed to radiation, typically we don't know the dose. And often we won't know the dose until the patient develops signs of radiation sickness. Initially, what we're dealing with are perhaps blast injuries, so soft tissue trauma, fracture care, ABCs, controlling hemorrhage, those sort of things. And then later, depending on the signs and symptoms that develop, weeks, months, or years later, we can determine the amount of radiation they were exposed to. As an example, it takes 500 rad of radiation for your hair to fall out. Well, if I was exposed to 500 rad of radiation and 2 weeks later all my hair fell out and nothing else happened, then that's when I would know how much radiation I was exposed to. Radiation sickness is typically destruction of a healthy immune system, destruction of adequate production of red cells, and patients with radiation sickness need bone marrow transplants. Radiation burns can be, again, extremely harmful if the patient is near a source. You don't have to be far from a source to actually be protected. As an example, if you're standing next to a package that's emitting 500 rad, which is a lethal dose of radiation, if I just step 3 feet away, now I'm only exposed to 55 rad. And I step 3 more feet away, now I'm only exposed to like 1.5 rad. So the further you step away from the source, the less likely you're going to have exposure. Most radiological burns from radiation will look like a thermal burn. It'll be very difficult to tell them apart. Now, with electrical injuries, remember that you can have severe damage throughout the body because we don't see what happens inside the body from an electrical burn. There may be an entry and an exit wound. Certainly, if there is, you might be able to track the organs that are in the path of that entry or exit and make an assumption that they are injured. Respiratory and or cardiac arrest are possible following electrical injury. Bones can be fractured from the violent muscle contractions or from being thrown to the ground from a volt or thrown off a ladder from a jolt of electricity. Managing electrical burns is like all trauma, begins with ABCs. Is the airway open and maintainable? Are they breathing adequately? Do I need to provide CPR? Do I need to defibrillate this patient? If not, are there any evident signs of shock? And if they are, treat for shock, administer high concentrations of oxygen, those sort of things. If they've been thrown from a ladder or down to the ground, you may have to provide care for spinal cord and head injuries, as well as extremity fractures. You want to look at the burns from electricity as you do any burn, as far as the degree, depth, those sort of things. Again, if there is smoldering areas on the body, you do want to cool those down as you would any sort of burn. Then once clothing is removed, jewelry from the fingers or feet are removed, then apply sterile dressings and transport them to initially a trauma center, and they may be transported further sometime later to an actual burn center. Now, when it talks about applying a sterile dressing, there's a variety of different things that you can put on as well. Our preference is to wrap saran wrap around smaller burns of the extremities. Saran wrap is clear, so you can see the wound underneath. It does prevent any further heat loss. It does keep the bugs out, because many people will survive their burns only to die from an overwhelming infection. So the dressing is any material that's applied to the wound to control bleeding and prevent contamination, and then a bandage, as we mentioned earlier, is any material used to hold the dressing in place. So here is a dressing, and a universal dressing is typically a 4x4, but if the wound is much larger, there are 8x10s, there's 5x9s, kind of like photographs. They're in different sizes and different thicknesses, but you're going to begin with direct fingertip pressure to control most hemorrhage. If it is a massive, then you're going to go right to a tourniquet. If it's a hole in the chest, you need to form an airtight seal. So use the foil package on Vaseline gauze is airtight. So you could, place that sterile side towards the open wound and tape off all four sides to seal the hole in the chest. Now, some would tape off just 3 and allow the the untaped side to be a vent should they develop pressure inside the chest. But research shows that, it doesn't matter. It doesn't matter whether you do 3 or you do 4. Here is just a standard spiral dressing, spiral bandage using roller gauze to hold a dressing in place. You want to take standard precautions because you're dealing with blood. You want to expose the wound, clean it if you need to, cover the entire wound with a dressing, and then hold the dressing in place with a bandage. Now, you may, if the bleeding is significant, apply direct fingertip pressure and the use of a hemostatic agent, dressing saturated with a hemostatic agent packed into the wound with fingertip pressure. Or if the bleeding is massive, go right to a tourniquet. Just remember that once you put a dressing over a wound, it's just not advisable to remove it. Removing it will cause any clots that have started to form to wash out, and you'll be back to square one. Do not bandage too tightly or too loosely. Do not leave loose ends. Do not cover the tips of the fingers or toes, because you want to be able to assess skin color, temperature, moisture. And remember to cover all edges of the dressing to help prevent the wound from becoming contaminated. And with that, if you have any questions concerning soft tissue injuries or what types of dressings and bandages and bandage applications there are, I'm sure you'll be practicing bandaging wounds in your lab. So questions, you know how to get a hold of me. Have a great day.